Dear colleagues, today I will bring to your attention the case of a fetus in a pregnant woman who came to our attention at 11 weeks and 6 days of gestation in order to undergo first trimester screening tests. Let us recall that the latter has several objectives, including determining the location of the pregnancy, the number and polarity of the fetus or fetuses, establishing the number of placentas and amniotic sacs in the case of multiple pregnancies, and obtaining the CRL measurement, understood as the crown rump length. In addition to the biochemical screening that may be performed by patients at this stage of pregnancy, the ultrasound examination is also used as part of the assessment of the risk of fetal aneuploidy. In this regard, it is essential to identify findings commonly referred to as soft markers, which are ultrasound signs that, while not indicative of fetal malformation and can in fact sometimes be present in healthy fetuses, serve as a warning indicator for fetuses affected by chromosomal abnormalities. The most recent medical literature identifies the main soft markers useful in clinical management as increased nuchal translucency, absent or hypoplastic nasal bone, hyperechogenic bowel, and borderline omega-3 ventricle. In the case I will present to you today, the fetus had a CRL of 60 millimeters, corresponding to 12 weeks and 2 days of gestation. We then proceeded to measure one of the fundamental ultrasound markers for assessing the risk of chromosomal abnormalities, namely nuchal translucency, which corresponds to the space at the back of the fetal neck, and in this case was found to be above the 99th percentile. Specifically, it measured 5.4 millimeters. Let us recall that the mechanisms underlying the increase in NT are not known, although the literature suggests a correlation with reduced cardiac function, alterations in the cardiocirculatory system, dysfunctions of the jugular lymphatic drainage system, or even increased intrathoracic pressure. This therefore requires the patient to undergo further diagnostic investigations, which we will soon describe in detail, bearing in mind that increased nuchal translucency is associated with significant chromosomal abnormalities, including trisomies 13, 18, 21, and in some cases also DiGeorge syndrome, also known as chromosome 22 deletion syndrome. Given, as previously mentioned, the strong association with cardiocirculatory anomalies that are often found in these cases, the examination of the heart was begun. What we are observing below corresponds to the left side of the fetal heart, while above is the right side. During the examination, what we observed was a significant predominance of the right-sided cardiac chambers, to the point that in the initial scans the fetal heart appeared almost univentricular. Then, with the help of color Doppler, the right side was clearly visible, and after a careful study the left side could also be visualized. Both ventricles could thus be identified, although there were significant differences in size between them, with the right heart being enlarged. The edema, which was already notable given the increased nuchal translucency, was also present in other areas, specifically in the thoracic region, as can be seen in these images. The three-vessel view then appeared abnormal, with a reduced caliber of the aorta, suggestive of a hypoplastic left heart. At this point, we proceeded to the Doppler study of the ductus venosus, a fetal blood vessel that diverts oxygenated blood from the umbilical vein to the right atrium, which then passes through the foramen ovale and is distributed throughout the body, ensuring tissue oxygenation. It is very important to study the flow in the ductus, which under normal conditions is antegrade, pulsatile, and triphasic, whereas in cases of aneuploidy or cardiac malformations, it is characterized by an absent or reversed wave during atrial systole. In the case of the fetus we are observing, a reversal of the ductus wave was detected. Let us recall that this latter wave is a positive wave detected during the contraction of the right atrium, and its reversal can be indicative of fetal circulation problems or impaired cardiac function. In the presence of a reversed wave, it is important to closely monitor fetal growth and the condition of the fetal circulation through frequent ultrasound examinations. Moving on to the examination of the face in the sagittal section, the nasal bone was not visible. In fact, the typical equal sign created by the presence of the bone and the overlying skin was absent. Also in this case, data in the literature show that its absence is highly associated with chromosomal abnormalities, with a higher percentage of cases involving Down syndrome. During the examination of the fetal abdomen, the stomach was never filled, and therefore the gastric bubble was not visualized for the entire duration of the exam up to the end. In fact, it should be remembered that the failure to visualize the stomach is most often due to temporary gastric emptying. For this reason, even during the same ultrasound examination, before discharging the patient, it is necessary to check it several times. In any case, this situation should be re-examined on multiple occasions even after some time in order to suspect a fetal anomaly. In fact, it should be remembered that when the absence of the stomach in the abdomen is confirmed, it can be associated with esophageal atresia, tracheoesophageal fistula, diaphragmatic hernia, anomalies of the central nervous system, cardiovascular and genitourinary anomalies. Furthermore, its absence is more frequently observed in trisomy 21 and 18. The examination then proceeded to the study of the fetal appendages. The placenta, located anteriorly, was normal. The umbilical cord, correctly composed of 2 arteries and 1 vein, had a paracentral insertion. It is important to emphasize once again that the presence of a soft marker does not clearly and unequivocally indicate what the risk is or what the appropriate course of action should be for the doctor and the patient. The lack of certainty makes it necessary for the ultrasound physician to report it, to inform the patient and her partner, and in certain cases to request further diagnostic investigations, including invasive ones. In fact, at the end of the examination, counseling was provided to the couple regarding the significance of the clinical finding and the risk of progression to more severe forms. Therefore, genetic counseling was recommended in order to perform invasive fetal karyotyping and to search for mutated genes associated with rasopathies. Finally, pediatric cardiology and cardiac surgery consultations were recommended, as well as ultrasound follow-up and fetal echocardiography.